This conference will now be
Hello,
recorded.
Estevo.
Welcome, dear guests and dear friends, to the virtual hub of Online Cardiology Club. This is Sercan Okutucu, interventional cardiologist from Ankara, Turkey, and I will be moderating today's session. We have an interesting topic today, namely intra-aortic balloon pump, Impella and ECMO, how, what, and when to use these options. As we know, there are several types of percutaneous mechanical circulatory support systems, but none of them is ideal for all patients. Therefore, it's crucial to understand this topic for better practice. During this important session, you may write your questions or comments to the chat box, and I will ask them to our speaker after the presentation. So let me introduce our speaker today, Dr. Giulio Russo. As a short introduction, Dr. Russo is an interventional cardiologist from Rome, Italy, and Zurich, Switzerland. I should firstly tell that Dr. Russo is a very kind and positive person besides his scientific excellence. He published a lot on mechanical circulatory support, coronary and structural heart intervention, so you can ask your questions to our expert. And I think we shouldn't lose more time from our session. Thanks a lot, Giulio, for accepting to speak, and you may start when you wish.
Thank you, Serkan, for this kind invitation, this very kind introduction. So the topic is very wide and very complex, so let's go straight to the presentation. Those are my disclosures, and this is the agenda. So we will touch the high-risk PCI and the cardiogenic shock, which are the two main fields of application for these devices. So let's start from the high-risk PCI and what high-risk means. High-risk is refers to the successful or unsuccessful PCI. It may be angiographic, procedural, or clinical success. And of course, the significance and the meaning of risk over time has changed a lot. If we compare the results of the very first registries about angioplasty by Andreas Grunzing in 1982, we see the number of emergency coronary bypass, myocardial infarction, and in-hospital deaths. And if we compare with the results in 2009, we see how the emergency coronary bypass, the myocardial infarction rate has decreased a lot. And by the way, the number of PCI performed in patients with low ejection fraction and three vessel disease is increasing during the last years. And anyway, the patients that we are treating are mostly low risk and intermediate risk patients, and least treated population are the high risk patients. What are the high risk patients? So in general, if we consider the anatomic coronary risk and the comorbidity risk as assessed by the syntax score for the coronaries and the STS score and the Euro score for comorbidities, we can see that high-risk PCI is on the right. So high comorbidities and medium-high complexity from the coronary standpoint. And but if we base our assessment only on syntax score, Gray score, Euro score, well, we may end up in some confusion, and there might be different indication according to different points of view. For example, all these scores take into account the age of the patient, and here we see that also patients over 8 years old have a higher mortality, of course, but the mortality has improved over the last years. No scores take into account the frailty, which affect both the 30-day mortality and also the 1-year mortality. Now we have different definition, and it's very interesting to observe how the same journal published two different definitions in 1 year. Of course, most of the parameters are very similar, very close to each other, but still there are some differences. And mainly we base on, of course, coronary angiography. Then we want to know the echocardiogram, so usually LV ejection fraction, and also valvular heart disease. But again, it's very important also to look at the patient, because those kind of patients on the right, maybe the surgeons would not love operating them. For this reason, the concept of a high-risk PCI takes into account different features that goes from the coronary technical complexity, hemodynamic compromise, and also patient comorbidities. So let's see what are the device and their main features. The intra-aortic balloon pump is maybe the most used one. It is ubiquitous, so it's very easy to find an intra-aortic balloon pump in a cath lab. It's very easy to use. It has large bore sheets, but no more than 9 French. Well, the weak point is that it provides only a slight increase in cardiac output, and it is synchronized with the cardiac cycle. Then we have the Impella. Impella can provide a much solid cardiac output, much solid support, and does not require a stable cardiac rhythm nor native cardiac output. Of course, it is more expensive and it is not ubiquitous like the intra-aortic balloon pump. It has a larger bore sheets and has some contraindication, which may be the severe aortic valve disease, but also the presence of a thrombus into the left ventricle, for example. And finally, we have the ECMO, which provides a very strong support in terms of cardiac output. Again, does not require a stable cardiac rhythm, but has some disadvantage because it requires larger bore sheets that goes up to 24 French, and it increases also after load as it pushes blood against the normal direction of blood flow. So it increases LV stasis and LV distension. Just a few words about the PV loops. Here on the right, you can see the PV loop of a patient with a reduced ejection fraction as compared to a patient with normal heart. Now, here you see the kind of effect that an intra-aortic balloon pump has on the PV loop. Here the Impella below, and here the ECMO. What you can notice is that while a patient with a reduced ejection fraction tend to move his PV loop upwards and rightwards, the intra-aortic balloon pump and the Impella try to keep it again on the left and downwards. On the contrary, ECMO still increase the PV loop and goes rightward and upward. Those effects can be easily understood in this tab, where you see some of the hemodynamic parameters, the most important hemodynamics parameters, such as the cardiac output, but also pay attention to the PDA, which is the PV area, which is a surrogate of the cardiac work. And here you see that ECMO increases cardiac work of 16%. Let's consider that this tab is mainly based on the Harvey software, so it is a simulation, but it's just to have an idea of the kind of support that each device can give us in a patient with reduced ejection fraction. Now, let's move to the indication. If we open the European guidelines and we try to write MCS or LVAD, there's nothing about high-risk PCI, but only things about cardiogenic shock. Instead, on the American side, we have an indication, class 2B indication with a level of evidence C. So there is a weak recommendation to use hemodynamic support in a risk patient, but still we have an indication in the American guidelines. Well, in spite of this lack of indication, if we look at the trend of the use of the mechanical support, we see that the intra-aortic balloon pump has a stable curve, is of course the most used one, but Impella and ECMO is increasing significantly over the last year, both in patients with cardiogenic shock, but also in patients in a high-risk PCI setting. And let's see one by one what this device can give us. So those are the curves from the main study about the intra-aortic balloon pump in high-risk PCI, where they compare the use of a planned intra-aortic balloon pump against no planned intra-aortic balloon pump. And as you can see from the long-term follow-up, there is a significant difference in favor of a planned balloon pump. But we must consider that with 301 patients, this study, this sample size is underpowered to have a good estimation of mortality. And also another point is that no planned intra-aortic balloon pump involved also some patients which required a bailout intra-aortic balloon pump. And also there is always a price to pay for all these devices. In this case, we can see that the bleeding and the access site complication is much higher in the elective intra-aortic balloon pump group as compared to those without intra-aortic balloon pump. So the main message, in my opinion, from this study is that it's very important to have a careful planning of the procedure, because otherwise it might be too late if you need any device. Let's move to the Impella. Again, the use of the Impella has increased a lot. Here we have the results from the main trial comparing the Impella 2.5 to intra-aortic balloon pump. And as you can see on the right scheme, on the right curves, the per protocol analysis, the Impella 2.5 has a better outcome as compared to intra-aortic balloon pump. However, if we look at the recently published results by Amin, we see that death and bleeding and stroke were much higher in the Impella era. But of course, all studies have some limitation, and in this case, this is a registry from the USA experience. There were some patients, more than 1/3 of patients involved in the study with cardiogenic shock. Also, no angiographic and echocardiographic details were provided. We didn't know which Impella pump was used, and also we have no information about access site management. So, of course, the Impella in this registry, after the introduction on the market of the Impella, the death increased, the bleeding increased, but we should know which kind of patient died, and also some angiographic and echocardiographic details. So how to interpret this data? In my opinion, there are three things that should bear in mind in these cases. First, the operator experience has an impact on the outcome. Second, the completeness of revascularization is also something that should be taken into account. As you can see from the PROTECT 2 trial, there was a significantly higher rate of rotational atherectomy in those patients, in those patients with Impella 2.5 support. This means that maybe operators felt more comfortable with a strong support, such as the Impella support. And completeness of revascularization is is very important if we consider the revascularization index, which is a ratio between the BCIS jeopardy score and pre-procedural and post-procedural. We can see that those with a higher revascularization index, so those who have a more complete revascularization, has a better survival. The third thing to consider is the importance of LV ejection fraction. Of course, the poorer the LV ejection fraction, the poorer the outcomes. From the US PELA registry, we saw that most of the patients improved their LV ejection fraction by at least 5%. Some of them, of course, got worsened, but most of them, let's say, that improved the ejection fraction. And again, these data were confirmed also in our registry. But what is more interesting is that, again, the revascularization index may have an impact on the improvement of LV ejection fraction. So the more you revascularize, the more the chances to improve the LV ejection fraction. Finally, there's one thing that is not written anywhere, no registry and no randomized control trial can show us. Here is what happened in our cath lab a few years ago. If you see during the inflation on the left main, you see that the yellow curve, the pressure curve, flattens. And what is interesting is that if you ask the patient in this moment how he feels, he says that it's all okay, because the cardiac output here is provided by the Impella. As you can see, 3.1, 3.2 liters per minute. And as soon as you deflate the balloon, the pulsatility starts again. So can we predict who is going to flatten the curve? Well, it's very difficult to answer this question. Of course, throughout the procedure, there are some differences as regards the systolic blood pressure and the mean blood pressure. The patients that are more likely to go to have a critical blood pressure drop are those with a higher BCIS jeopardy score. So those who have a higher myocardium at risk. As regards the ECMO in high-risk PCI, well, there are some case reports, some case series with 10, 15 patients. Of course, it can be used, but well, it's much uncommon. And this is our local protocol for the use of these devices. Of course, you have to consider the risk of hemodynamic collapse, the device contraindication, and also the arterial axis. But let's pay attention to the green box, because in my opinion, preparation is really crucial. There are some cases in which maybe no one of these devices is strictly indicated, but in those cases, it can be very useful to be prepared for a bailout insertion of any of these devices. Be prepared in our centers means that you already gain the femoral access. You can leave only the wire, or you can also place the sheath introducer. But it's also important that all the team, so the technicians, nurses, are prepared for a bailout insertion. But well, when we talk about these devices, we only consider the hemodynamic effects and the mortality. But an important part of the mortality is made also by the vascular and the bleeding complication. And here you can see, both in the setting of high-risk PCI and the cardiogenic shock, that the larger the sheath introducer, the higher the risk of vascular and bleeding complication. So it is very, and of course, bleeding and vascular complication may impact the long-term mortality. In this very recent study, the ECMO and Impella were independent predictor of severe bleeding and vascular complication. So it is very important, the vascular access site management. And here you see these data coming from the TAVI experience, but it's something that, in my opinion, can be applied also to the LV support systems. So those who used the femoral access for the secondary access, so those who performed the angioplasty through the femoral artery, they had a higher vascular complication as compared to the transradial ones. And if you look on the right on the histograms, you see that again, if you use both the femoral arteries, there is almost 1/3 of patients that have troubles, have issues with the secondary access. So it's not a minor topic. And of course, not only the secondary access, but also the first access, so the one of the LV support device is even more important. Here, it is the technique that we use in our center in Rome. It is an angio guide wire ultrasound technique where the J-tip wire is placed going through the radial artery, is placed exactly where we want to puncture. Then going with the ultrasound probe, we localize the J-tip and we puncture exactly when we want to puncture without the hand exposure to the X-ray. Now, let's move to the cardiogenic shock, which is even more complicated as a topic, because again, here we have different definitions according to the different trials. As you can see, the shock trial is the only one that included the cardiac index and the wedge pressure. But anyway, the guidelines here provide some more details as compared to the high-risk PCI. And well, they say that the mechanical support can be considered, but we have to take into account also patient age, comorbidities, neurological function, predicted quality of life. So again, very difficult choice. This is the position statement that was published 2 weeks ago. And again, here you can see that the MCS, so the mechanical support, are mentioned only in case of mechanical complication or if severe hemodynamic instability occurs. And again, the indication is not very strong, it's a level of evidence C. But let's see device by device what the data suggests us. This is the SHOCK 2 trial, which showed no benefit of the intra-aortic balloon pump over controls. And recently also the 6 years follow-up has been published, and again, no significant difference. So what was the reaction to this? The reaction was that the use of intra-aortic balloon pump in the setting of cardiogenic shock decreased, and Impella, tandem heart, and ECMO use increased over the last years. So let's see what Impella performed in the trials. And well, both the ISAR shock trial and the IMPRESS trial failed to demonstrate a superiority of Impella over the intra-aortic balloon pump. And more recently, not only was demonstrated that there was no superiority in terms of mortality, but also the peripheral complication and life-threatening bleeding were significantly higher in the Impella group as compared to the control. Finally, as regards the ECMO, very few data, very few patients, But it seems that according to the available data, the ECMO performs better than intra-aortic balloon pump, not so much better as compared to Impella or tandem heart. What about the combination of ECMO with intra-aortic balloon pump or with Impella? Where the LV unloading in the setting of cardiogenic shock is always seems to be always very useful, either if you use the intra-aortic balloon pump, but also with Impella. And this is the extended tab, with including also the combination of intra-aortic balloon pump and Impella plus ECMO. And as you can see, the performance are much better if you combine ECMO with the intra-aortic balloon pump or Impella. So the question is, are the PVAD useful in the setting of cardiogenic shock? And of course, this is a consideration by Thiele in this very recent position paper about cardiogenic shock. And of course, there is a percentage of patients, around half of the cases, which they do not survive to cardiogenic shock. Maybe these patients are those who may benefit from an LVAD support, but it's very difficult to understand who they are and which of these devices should be used. Anyway, this is our local protocol for the use of these three devices in the cardiogenic shock setting. And as you can see, the intra-aortic balloon pump is used mainly for the mechanical complication of myocardial infarction, and for those patients who are at risk of cardiogenic shock. And instead, Impella and ECMO are considered for a stronger level of support. What is very important also, in my opinion, is the concept of futility, which is something, again, very difficult to assess in the setting of cardiogenic shock. So in urgency or emergency, there are some scores and which may help, but of course they have their limitation. And there are some general consideration, let's say some common sense consideration that should be done in these cases. Again, it's very difficult to find one rule that fits for all these cases. Most of our answers, most of our questions will get an answer in a few years upon the completion of these trials. In my opinion, the DANGER trial is one of the most interesting one, comparing the Impella and the intra-aortic balloon pump in patients with cardiogenic shock following myocardial infarction, but also the reverse trial, which compared the combination of ECMO plus Impella and ECMO alone, will give us some very interesting insights. For the moment, my recommendation is always to fasten the seatbelt and to wear the parachute if you have to do a long jump. Thank you very much.
Thanks a lot, Giulio, for this enlightening and entertaining presentation and clear messages. So there is one question from the audience, that what is the frequency of the use for this device in your centers? Actually, I want to ask to you regarding with high-risk PCI. For example, what is your protocol? Do you prefer intra-aortic balloon or Impella in your clinical practice, and how do you choose these options?
Well, I think that the most used device in our local experience is the Impella in the setting of a high-risk PCI. But as I showed in our flow chart, we assess very carefully the risk for hemodynamic compromise, and also if any contraindication for Impella should occur. So if we need a strong support, and if we aim at a complete revascularization, we feel much more comfortable with Impella as compared to intra-aortic balloon pump. If the patient is only at risk for hemodynamic compromise, then we may decide either for device preparation without any device implanted at the beginning of the procedure, or we may decide also for intra-aortic balloon pump. Serkan, you have the mic off. I cannot hear you.
Yeah. Can you hear me? Yeah.
Yeah. Yes.
Yeah. There is one question from the audience. I think they are asking about VV ECMO. You, of course, we are talking now about the VA ECMO, but now the VV ECMO is popular, especially in COVID-19 ARDS. Can you comment on this?
Yes, and well, our talk was mainly about VA ECMO. I didn't specify it. And
Yeah.
As regards the COVID, well, there are contrasting data in my opinion, but I think that it might be useful. Again, if we have poor data in the setting of cardiogenic shock and high-risk PCI for the ECMO, it is even more difficult to discuss about the use of ECMO in this setting of COVID, and also due to the very recent, very recent results of a publication. I don't know how much reliable all these data that we are looking at are reliable. I wouldn't say that we should use for sure VV ECMO in this setting. It might be useful, but again, it's a case-by-case assessment probably.
Yeah. There is another question. What is your choice in advanced heart failure terminal stage with low cardiac output?
So maybe here we enter the chapter of futility, and it's a very delicate topic in my opinion, but I can say, well, very generally speaking, that in this case, sometimes you have to be brave enough to decide to leave the patient without any device, or if you don't feel just to leave the patients as it is, you may decide also to put an intra-aortic balloon pump just to decide to do something. But of course, the results that you expect are well, not so good. But again, here is very personal topic. It's very personal answer, and it's mainly related also. It's a team decision. Also, it's very important to share all these this very difficult decision with heart team, so with surgeons, heart failure specialists, ICU specialists, and if it is very advanced heart failure and you are sure that every treatment that you can do will be unsuccessful, then in my opinion it's worth considering not to put any device.
Thank you, Giulio. There is another question from Dr. Max Lacoste. He is asking that in elderly patient with less compliance of aorta, does the intra-aortic balloon still have the space?
Yes, I must say that in the cardiogenic shock, it's when you decide to use the intra-aortic balloon pump, it's sometimes difficult to have a proper assessment of aortic calcification, and well, I wouldn't well, at least in my center, we wouldn't we wouldn't base our choice upon the level of calcification of the aorta, but of course it may have an impact on the intra-aortic balloon pump performance.
There is another question, Giulio. What about the other alternative accesses that can be used for intra-aortic balloon pump or the Impella in patients with peripheral arterial disease?
Yes, I didn't show the some of our cases, but we performed also an Impella position through the transaxillary artery. There was a surgical cut down, and so it is feasible. Well, in my opinion, this is something that is true for all the alternative access. I think that you need to choose an alternative access, and you should try to master it. So it is true for the LVAD, but it is true also for the TAVR, for example. So if you decide to use axillary access, it can be done, but it's good not to change too much among the alternative accesses. And in my experience, the transaxillary one is the one that we know, and it is feasible, and but it is always good to have the surgeon around the cath lab, not only for the surgical cut down, of course.
Thanks, Giulio. There is another question from Dr. Mehriban Iskender from Azerbaijan. She is asking, could you speak about the data or trials which show high mortality risk in Impella versus intra-aortic balloon pump? I mean, comparative trials or data. I think you talk about protect.
Yeah, I talked in the setting of high-risk PCI. I talked about the PROTECT 2 trial, which is the main randomized trial. It was interrupted before the end for futility. So again, it didn't reach the power for the mortality. But there was a trend in favor of a trend. Well, there was a significance in the protocol analysis towards the Impella, so in favor of the Impella 2.5 over the intra-aortic balloon pump. And also very interesting, in my opinion, was the fact that rotational atherectomy was more used in the patients with Impella as compared to those with intra-aortic balloon pump. And in my opinion, this is due to the fact that the operator felt more comfortable. They relied on the strong support of the Impella. And as regards to the cardiogenic shock, the results both in the ISAR shock and the IMPRESS, and recent also data published last year, well, they failed to demonstrate a superiority of the Impella over the intra-aortic balloon pump. But again, it is questionable also because the definition of cardiogenic shock sometimes is very different, and also because if you include a patient in a study 15 minutes before he dies, of course it's very difficult to have a reliable data about these devices.
Thanks, Giulio. There is another nice question. What do you think about using Impella RP and Impella instead of Impella plus ECMO for biventricular failure?
So as regards Impella RP plus LB Impella, we have few experience. So my opinion is mainly based on the few papers published mainly by Federico Pappalardo, who has a lot of experience in this field. And it seems a very good combination, but to what I understand is, well, if the heart recovers, you can see it in the first 24-48 hours. Otherwise, Also, the combination of Impella RP and Impella left is going to give no results, is going to fail. As regards the Impella plus ECMO, is a combination that I like very much, in spite of course, the vascular and bleeding complication. But as I showed in the tab with the Harvey simulator, I think that the parameters provided by the combination of Impella plus ECMO are pretty good. And of course, it is also a matter of costs and vascular and bleeding risk.
There is another question from Dr. Khalid Alfavi. Can you highlight the best option for patients who are scheduled for imminent heart transplantation?
Well, very interesting question. Well, first of all, my center is not a transplant center, so let's say this as a first thing. And as regards the transplantation, well, I think that the one that can give you the best support, so for example, the ECMO, maybe is the choice to be done in these cases. But well, again, few data about this topic.
All right, my dear.
And we also know that Dr. Mohammed Saraf has a lot of experience regarding with the mechanical circulatory support device and as many area in cardiology. Mohammed, do you want to comment? It's one of your favorite topics.
Yeah, no, thank you very much. First of all, Giulio, thank you very much for this fantastic review and especially very updated review of literature. Most of them were very recent that most of us may not have had a chance to review. I pretty much agree with everything that Giulio mentioned, obviously. But the one thing is that he mentioned something, excuse me, let me close the door. He mentioned something about patient selection. I think this is really not about mechanical circulatory support. I think this applies to anything is in medicine, and not just talking about internal medicine. In surgery, in rheumatology, in neurosurgery, it doesn't matter. The patient selection and timing of intervention. Now, intervention, whether it's a pharmacologic intervention or surgical intervention or percutaneous intervention, I think timing is always the key. That goes without saying. I think one of the areas of, because it's something to look at the data and say, for example, balloon pump is no worse or Impella is no better than balloon pump. But it's a little bit, in my opinion, in my humble opinion, I think it's a little bit of an oversimplification. One of the areas that have been heavily misrepresented in all of these studies is no one really has looked into the function of the RV. If you look at the shock registry, the original shock registry that Judith Hochman published back in late 1990s, Naveen Kapoor actually has looked into this very extensively over the last decade or so. And one of the lessons that we learned is about 40%. It's almost 1 out of 2 out of 5 patients, to be more mathematically accurate. 2 out of 5 patients who came in with cardiogenic shock, now remember it was in the setting of severe coronary artery disease, also happened to have RV failure. Okay, so expecting that the RV is going to do fine just because you're addressing LV is really not going to cut it. I don't know how many of the friends and colleagues here are heart failure specialists or work with the LVAD patient population, but one of the most critical numbers when you want to take a patient for a surgical LVAD is to look into their RA pressure, to their CBP, which seems like a very simple index, but the outcome of we can already predict that if you have 2 patients, everything else is exactly identical. Both have severe, let's say, ischemic or non-ischemic cardiomyopathy. That's really irrelevant. Everything else is the same. Both have very low peak VO2, let's say 10 milliliters or so per minute during peak exercise. But one of them has an RA pressure of 15, the other one has an RA pressure of 6. You already know, without knowing anything else, even if you don't know cardiac output, if you don't know anything, you already know that the patient who has higher RA pressure is going to have worse outcome, because that's a patient who's going to have RV failure. So one thing that I personally pay attention to, and this is again something that Naveen Kapoor has extensively published and has focused on over the last 5 to 8 years, is looking into the RV function as part of the circulation. I think we as a cardiology community has historically ignored right ventricle, because first of all, we don't understand it very well. The anatomy of it is very difficult. Understanding the function of it is very difficult. We're still trying to define, okay, what is a normal RV function? When we look at echo, you can show one echo of a patient with biV failure to 10 different experts, and if you ask them, okay, how bad is the RV function, you may get at least 5 or 6 different opinions. So I think it's great to know the data. I think this is a fantastic summary of the data, but we also have to be mindful of the entire circulation. It's just too simplistic to think that if we fix the LV and left ventricle, then everything else should be fine. We always have to keep in mind that the left ventricle would not work unless the right ventricle works. If you don't have a preload to your left ventricle, it doesn't matter if you put an Impella CP or Impella 5 or Impella 5.5 now that we have it in an empty ventricle. At the end of the day, it's still an empty ventricle. So understanding the hemodynamics, flow dynamics, and all the different perspectives of circulation is tremendously important. So I personally don't have any preference of one over the other devices. That said, the one device that I use the most is Impella for a number of reasons. Based on the pressure volume looks that Giulio showed, it reduces the preload, which is good for the ventricle, especially in the setting of ischemia, because that's how you reduce myocardial oxygen consumption. Reduces the afterload, so it really helps a failing ventricle. And most importantly, in terms of access, I think in this day and age, no one should get access without ultrasound. So we really have to know where we're going. Just using ultrasound and micropuncture has tremendously decreased the vascular complications, as Giulio showed and mentioned a number of times, whether it's TAVR or any large bore access. Once you have vascular complications, obviously outcomes are worse, no matter what you do. And most importantly, with one single access, I can do a very complex PCI. So the way that we do it, in at least the way that I do it, is that I put the Impella sheath, the peel away sheath, and through the Impella sheath, I put a long 7 French or 8 French sheath. Usually 7 French is more than enough, 7x30. And then I can do as complex of a procedure. I can do the most complex CTO. I can do the most complex left main without worrying about hemodynamics. So I think we have to stay open-minded. We may learn that ECMO is the best device. In theory, it doesn't seem like it, but who knows? Again, data is always, we always have to be careful to jump into any firm conclusions. But I think among all the devices, Impella seems to have the best pressure volume loop, and therefore it's the most friendly to the heart. One question that one of the colleagues brought up in regards to Impella RP versus Impella RP plus Impella as a BiVAD, it's fine, it works. I've done it twice ever, but both patients had excellent lung function. They didn't have any bad COPD. So if you have a patient who you cannot oxygenate, then Impella by itself cannot help you for oxygenation. So that's another perspective of mechanical support, that when we want to choose it, we have to choose it wisely. Okay, does my patient have a massive PE and I cannot oxygenate that or not? That may be another component that you have to keep in mind.
Thanks, Mohammed. And also for the intra-aortic balloon pump, there are also many other things that we should keep in mind, like correct timing, correct positioning, and many device setting. And what do you think for Impella? I don't have much experience with Impella. Is it like intra-aortic balloon pump? What are the critical things?
Well,
Giulio?
yeah, it's the same. Did you ask to Mohammed or to me? It's the same. Mohammed is also very okay. Let's.
Giulio, go ahead.
I give my position. Of course, correct position of intra-aortic balloon pump, so the closer to the aortic valve, the CC, and many other things may have an impact on hemodynamic results. But as regards the Impella, well, usually we try to balance the vascular risk and the level of support. I mean, with the Impella 2.5, it is 13 French, and you may go up to 2.5 liters per minute. And only by adding 1 French, you may have a support of up to 4 liters per minute. So again, it depends on the kind of support that you need, and but usually for 1 French more, you may decide to have a stronger support. Now the Impella CP, I think that if I'm not wrong, has included some parameters. I mean, the new Impella machine can calculate the cardiac power output and many other hemodynamic parameters online. And if I'm not wrong, this can be applied to the Impella CP, and this increased the cost of Impella CP a lot. And so this is also another thing to consider. Finally, just to comment on what Mohammed said, well, it's everything is very, very true, and right function is something that we usually consider before deciding the kind of support. Of course, if the right ventricle doesn't work, intra-aortic balloon pump or Impella will be useless. And again, it's very difficult to try to simplify such a complex reality. So I can spend time to create all the flow charts and all the definitions that we want, but in the end, there are several parameters that need to be considered, and well, that's true.
So we are waiting your paper when it will be published.
It is under submission, but I showed you a kind of preview, and well, the paper discusses about all these difficult choices and all these points that were raised also during the discussion are almost all addressed in this paper. But again, I must already admit that 5,000 words are not enough to cover all these questions. It's very difficult.
Can I ask a question, Saga?
Yes, of course,
Sure.
Dylan.
Well, I was thinking here, Mohammed as well, and everybody. A plane is to fly, shoes to walk. I can't wait in using shoes and go to gym. That shoes will give me muscles. So sometimes while waiting that Impella or some devices give impact on mortality, the relationship cause effect. And sometimes the device should be used to work. And so we think about which is the work of device. And if the device is working well, impact on mortality is so complex. because this patient has a multitude of variables, and sometimes we do not handle all. What do you think?
Well, the connection was a little bit unstable, but to what I understood is, well, you were just commenting on the complexity of the results. It's very difficult to draw the conclusions
Are you hear me
from the available
now?
data. Yeah,
Are you hear me?
yeah,
To be clear,
yeah.
device help hemodynamics. Patient is more complex than hemodynamics. Success of device is based on device itself helping hemodynamic or device having impact on mortality. What is your opinion? To be clear.
Well, in the end, the answer is very easy if you put on the table one of your relatives. What do you want from your relatives? You want that the patient, starts his life again and can live as long as possible. So, for me, the mortality is maybe the main thing, the main driver. Then comes also the hemodynamic parameters. Also, if you consider the data from the ESAR shock trial, if I'm not wrong, or the IMPRESS trial, the Impella performed very, very well from the hemodynamic standpoint. But in the end, the mortality was not different from between Impella and intra-aortic balloon pump. So it's very complex topic. I just mentioned vascular access and bleeding has the price to pay for these devices, but they are not the only things that should be taken into account in this condition.
If I may jump in here, so I totally agree with you, Giulio, that mortality is the only index that you should count. You know what else improves hemodynamics but increases mortality? Milrinone. You know what else? Dobutamine. You know what else? Norepinephrine and epinephrine. Essentially, any inotrope or vasopressor that everybody uses in the CCU, ICU, wherever. Yeah, gives it. You know, if for those of you who are interested in philosophy as well, once you go to the doors of heaven, they don't ask you what was your hemodynamics when you died. Once you're dead, you're dead. So to me, hemodynamics is completely irrelevant. And I think the point that you are bringing about, I think you're referring to IMPRESS trial, Giulio, about the hemodynamics with Impella was significantly better, but the outcomes were exactly identical. It was IMPRESS trial, but I know that everybody says IMPRESS showed that Impella and balloon pump are identical in terms of efficacy, which technically it is correct. But that was, I think that the name, the title of that study should be changed from cardiogenic shock to cardiac arrest. 100% of patients who were randomized into that study had chest compression and had cardiac arrest. Cardiac arrest is not cardiogenic shock. The same way that cardiogenic and acute MI with cardiogenic shock is not any acute MI. So we have a full spectrum. We have a completely normal, healthy patient that we never talk about, right? To non-obstructive CAD that we should still not talk about because they should never come to any MCS. Then to single vessel disease, then to 3-vessel disease, then we have acute MI, then we have acute MI with cardiogenic shock, then we have cardiac arrest. The patient who has a cardiac arrest, by default, by definition, has YV failure. And not only that, they have actually universal ischemia. They are ischemic in the brain, they're ischemic in the head, they are basically ischemic everywhere, kidneys, liver, everywhere. So expecting that putting an Impella CP, or for that matter, balloon pump, in someone who's already had a cardiac arrest and has had chest compression, and then expecting to see a different result is just a little bit unfair to not just Impella, to any device. Because you can put them on ECMO, they're not going to survive. You can put them on anything, they're not going to survive. Even if you bring everything back, if the patient's brain dead, they're still dead anyway. So that's why I say that it's one thing to review the data of and also these registries in terms of, okay, who's dead and alive. And I know that pure clinical trialists say that just count the bodies. I don't care anything but mortality. Fine, that can be a strategy. I personally don't agree with it, but that's a strategy. But at the same time, you also have to look at the details of every study. The problem with Twitter these days is that everybody just looks into the conclusion and the title, and they come to talk about, to Twitter that this study showed this, and then we have 140 characters to put your opinion about a very sophisticated clinical trial, or clinical trials for that matter. Now, one more thing that I wanted to mention about the question that you referred to, Sergeant, about the balloon pump. If you look at the complete name of the balloon pump, what is IABP CP stand for? It is intra-aortic balloon pump counter pulsation. The difference between balloon pump and all the other devices is that balloon pump is a misnomer. It's actually not a pump. It's just literally a balloon that goes up and down. There is no pump in it. Balloon pump is most effective when the heart is the healthiest. The name, if you go back to the name, is counter pulsation. The heart should be able to generate a pulse with which the balloon pump can counter pulse. Okay, and initially it was not even considered a device for heart failure, for that matter. It was initially designed to increase the coronary perfusion pressure to reduce ischemia in patients who had severe coronary artery disease. So, and then later on, people learned that, okay, it seems that it reduces the afterload a little bit, and then came to a heart failure world. But balloon pump as an MCS is the same way that if you expect that that a 747 goes to the moon, fine. 747 flies, but it can never reach the moon. Yeah, I mean a shuttle, and the shuttle may look like an airplane, but they're designed completely for different perspectives, for different goals. So I never understood, and I still don't, why there is so much focus on a device that was not even initially designed for something that we expect that to change. Now, Impella is different. PHP, which is another axial pump, is different. There are other pumps in some of them are at the animal stage. I know, for example, that CSI is working on an MCS device. There are different designs now. Tandem heart is another mechanical support that we didn't really talk much upon. That's actually an excellent device for patients who have mechanical aortic valve, or they have very severe aortic stenosis, especially patients who have severe AS who are in shock and you cannot safely go across the aortic valve. So that's why I say that I personally don't have a special bias towards any device, is that because I think it's like anything else in medicine. You have to look at the patient and look and decide what's best for this patient in this condition at this hour. I may start with a balloon pump someone who's ischemic and EF is still 40-45% and is complaining of chest pain, but once I see that the lactate is going up or they're not doing well, I may switch that balloon pump to Impella. So again, it's as Giulio mentioned, it's very difficult to put such a broad topic into a 30-35 minute conversation and come up with a formula. You always have to dance on your toes and be ready to change your strategy at a split second when the right time comes in.
Thank you very much, Mohammed, for your nice experiences that you shared with us. We learned much from them. And thanks, Giulio, for this excellent presentation. We already discussed in 30 minutes about this topic after the presentation, so we have come to the end of the presentation. So let's do our final usual show for the people that are able to open their camera. Is it possible to switch on their camera? Yeah. Yeah. We can see many faces. Yeah, hi. Hi, everyone. So,
Everybody.
So thank you for your attendance, and thanks for all. See you next week. Okay, bye.
Bye.
Thank you.
Thanks, Agam,
Bye.
Giulio, Mohamed, Estevam, Ana, and everybody. Thanks so much. We appreciate it.
Thank you
Bye.
very much.